respected MCh Chairperson, Dr. ML Surankarji, Medical Director, Dr. S.S. Jaiswal, my faculty colleagues, dear students, ladies and gentlemen. A very good morning and warm welcome to today's CCR by the Department of Nuclear Medicine. Thanks to the architect of Indian Nuclear Energy Program, the visionary Dr. Homi Jehangir Bhabha, India is at the forefront for the peaceful uses of atomic energy. Today, Department of Nuclear Medicine, along with few other departments of the college, will be presenting a case showcasing the usefulness of atomic energy in the field of medicine. But before our residents present the case, a brief introduction and achievements of the department. Department of Nuclear Medicine at this college was established in year 2019 when the first PET-CT was commissioned in February 2019. Subsequently, PET-CT was only for the oncological services along with few neurological and cardiology indications, but general nuclear medicine gamma camera is also required. So in May 2020, a SPECT gamma camera was also added to the existing facility of the PET-CT. Thereafter, thanks to the management, the vision of the management, National Medical Commission gave go-ahead approval for the starting of MD in nuclear medicine with an intake of 2 seats in year 2021. As nuclear medicine is not only diagnostic branch, but lot of therapies also being done with the use of radionuclides, and these days radionuclide therapy is taking over the diagnostic field of nuclear medicine. So in year 2022, in the month of October, high dose therapy was also commissioned, and a year later MSc Nuclear Medicine Technology was introduced in this college. In 2024, a specialized synthesizer was added for the gallium chemistry, which is used by labeling few radiopharmaceuticals for the diagnosis and treatment of few specialized cancers like neuroendocrine tumors and prostate cancer. And last year, NMC gave approval for the increase of 2 more seats, and now we are having 4 MD seats in nuclear medicine. So currently the facilities available are 2 PET-CT scanners, 1 SPECT gamma camera, high dose therapy ward with 4 beds facility, in-house gallium and technetium-99 chemistry generators, MD seats 4 seats per year, and MSc intake of 15 seats per year. These are few of the represented pictures, PET-CT in the SRCC building and dual-headed gamma camera, and this is in the hematologist our second PET-CT along with radionuclide therapy ward and gallium chemistry unit. These are the generator which we get, like first is technetium-99 generator, and this is the gallium generator. This is the synthesis module for the gallium chemistry. We have 3 faculty members currently in the department, myself along with my colleague Dr. Tarun Jain, Associate Professor, and Dr. Ram Singh Meena as Assistant Professor, and they are doing great job for the PET-CT as well as SPECT investigation and therapy. MD, we have first batch in 2021, Dr. Gurdas Singh and Mansha Vora, both are well settled, and last year the 2022 batch passed out, and both the students are also doing good, one in Kota and another in Ahmedabad. Currently, we have the 3rd year residents who will be going for the examination very soon, and the 2nd year residents 2024 batch 2 and 4 this in 2025, actually in January 2026 were admitted. So these are the few diagnostic services using PET-CT as well as SPECT, PET-CT in the oncology major part, and SPECT we do lot of studies related to nuclear nephrology, cardiology, neurology, oncology, etc. And these are represented image, PET image, SPECT image, brain and cardiac. And department is also doing lot of intervention in the form of PET-CT guided biopsies, FNAC, microwave ablation and RFA, and till date about 1500 procedure has been done. Radionuclide therapy unit, 4-bedded unit which we have. These are the few images. We have low dose therapy for the Graves disease, that is benign disorder, carcinoma thyroid. We do prostate cancer therapy, neuroendocrine tumor therapy, bone pain, metastatic bone pain palliation, and radiosynapectomy for the inflammatory joint disorders. Apart from FDG in the oncology, we use many other tracers also, like FAPI, PSMA, Dotonog, Trivexin, Exendin, CXCR4. These all are for different types of tumors and are useful. So this is the department statistics since the inception 2019, but data is shown from 2021 till 31st of May. So in the first year, 2019, 1471 PET-CT scans were done, and thereafter slowly it was increasing. There was one dip in 2023, but thereafter again increasing until this May 26, we have done more than 2000 cases on the PET. This is a gamma camera, again slowly increasing, and this year already we have crossed 300 scans. And therapy, in 2022 when radionuclide therapy unit was commissioned, only 7 therapies was done, but thereafter department never looked back, and slowly increasing. Last year 150 radionuclide therapies was done, but this year till May again 150 therapies have already been achieved, the target which we did last year. So few conferences were attended by the faculty. This as Governing Council member of the National Academy of Medical Sciences, I attended NAMSCON 2025, and Asia Oceania Congress of Nuclear Medicine and Biology was also attended by me, and one of our students also got an award, Tomio Inoue Award, in the Asia Oceania Congress of Nuclear Medicine and Biology. This year we conducted and organized one CME on the prostate cancer theranostics in collaboration with the Department of Urology of the college, and it was very well attended. Nearly 200 participants were there. This is a few photographs from that CME. In addition to this planned CME, we are doing regular CME type meetings by the Jaipur Nuclear Medicine Club also, and few times we meet after 2 to 3 months and cases are presented there. Our residents, all the residents always present the cases there. In publications also, department is trying to do the maximum, though the staff is not that much. Till date, 34 publications have been done in various national and international journals of repute, and in last 2 years, just represented 2 publications, one in World Journal of Urology, other of Journal of Neuro-oncology. This is just representative, but there are other publications also. So future, with the help of management, we are planning, we think, wishful thinking, that we will be establishing one state-of-the-art in-house radiopharmacy lab for research and development of various radiopharmaceuticals, gamma probe for sentinel lymph node biopsy, SPECT CT machine. Currently we have SPECT only, but at present SPECT CT is the most important machine for general nuclear medicine investigation. Of course, whenever we will go for the change of PET CT, we will go for the digital PET CT and cyclotron and PET MRI. But for all this, of course, space and manpower is required. Then only we can start this. So with this brief introduction, I call upon my Department Resident, Dr. Kaushiki Shukla, to present the case, please. Thank you very much for the patient hearing.
Good morning, respected dignitaries, teachers, and my dear colleagues. I will be presenting the case of a 66-year-old female homemaker from Jaipur belonging to an upper middle class socio-economic status, diagnosed with follicular thyroid carcinoma and type 2 diabetes mellitus. The patient's past medical history and treatment history are essential for understanding this case. Therefore, they will be briefly reviewed here before discussing the present case. The patient first presented with a lump in neck in 2016, FNAC from which revealed follicular neoplasm. The CT neck and thorax were suggestive of lesion at 8th right rib and D10 vertebra. The patient underwent total thyroidectomy in October 2016, biopsy from which revealed a follicular carcinoma of thyroid with 1 out of 12 lymph nodes positive. She belonged to high risk and received 2 doses of 200 millicurie radioactive iodine therapy in 2016 and 17 respectively. She also received palliative radiotherapy to D10 vertebra in 2017, after which she was lost to follow-up. Coming on to the present scenario, the patient presented after a gap of 8 years in 2025 with pain in lower back radiating to the left lower limb for 9 months, weakness of both limbs for 6 months, numbness and decreased sensation below inguinal region bilaterally for 4 months, progressive difficulty in breathing for 3 months, and significant weight loss in the span of 9 months. The pain in the lower back region was insidious in onset, dull aching, radiating to the left lower limb, progressively increasing in severity, aggravated by movement, and relieved partially by analgesics with no history of trauma. The weakness of lower limbs gradually had a gradual onset, started 6 months back. Initially, she had difficulty in climbing stairs and rising from squatting position. The weakness progressively worsened, causing difficulty in prolonged walking and imbalance. Over the last 3 to 4 months, she required support while walking, and it was associated with stiffness in both lower limbs. Numbness was noted below inguinal region for the last 4 months. It was descending in nature and not associated with bowel and bladder involvement. Shortness of breath was gradual in onset, progressively worsening, aggravated on exertion, and the MMRC grading progressed from grade 1 to 3. She had no history of trauma or fall, no history of urinary incontinence, no history of fever, cough, hemoptysis or chest pain, no diurnal or seasonal variation of shortness of breath, no history of hematuria, melena or hematochezia, and no history of night sweats. The personal, family, and gynecological and obstetric history of the patient were normal. She was on oral hypoglycemic agents since 2004. She was not taking any thyroid suppression therapy. She was on tablet gabapentin, tapentadol, and buprenorphine patch for pain management with partial relief in pain. The patient was conscious, oriented, and cooperative. She was wheelchair-bound with a ECOG performance status of grade 3. Her BMI was within normal limits. The vitals were within normal limits except the respiratory rate, which was elevated, and the saturation varied from 92 to 95% on changing position. On inspection of neck, there was a linear scar at the lower anterior neck region crossing the midline. No visible swelling, ulceration, keloid formation was there, and there was no visible swelling in bilateral neck region. On local examination of lower back, the curvature of spine was maintained. There was no abnormal swelling or skin changes. There was tenderness at the back region at level of lower dorsal and lumbar region. The cardiovascular and per abdominal examination was normal. On percussion, there were dull notes at most of the sites in bilateral chest region. On auscultation, there was reduced air entry bilaterally with crepitations. So far, we know that this is a case of follicular carcinoma of thyroid, post-total thyroidectomy, followed by 2 doses of radionuclide therapy and palliative radiotherapy to D10 vertebral lesion in 2016. Then the patient was lost to follow-up and came back with presentation of dyspnea and pain in lower mid-back region. Now my question to the audience is, With this clinical history and examination findings, what could be your diagnosis? The differentials could be divided into two broad categories: malignant causes and the non-malignant causes. With systemic infections and inflammatory disorders being the non-malignant cause. But since this patient is a known case of metastatic follicular carcinoma and she presented with dyspnea and pain in lower back, the most probable differential, or there is a high possibility of it being metastatic lung or bone disease. With these differentials in mind, certain investigations were advised. While the routine blood investigations were within normal limits, serum TSH was significantly reduced. The tumor marker for thyroid carcinoma, which is serum thyroglobulin, was significantly increased. It was 1,11,175 nanograms per ml, which in a post-thyroidectomy case should be less than 0.2 nanograms per ml. To rule out any local recurrence, USG neck was requested, which did not detect any abnormality in thyroid or neck region.
Electrode replacement since 2016?
Yes, sir. She was not on any replacement therapy. With these possibilities in mind, and the clinical and biochemical investigations suggesting towards possibility of recurrence, chest X-ray and MRI spine were requested. Now I invite Dr. Ayushi from Department of Radiodiagnosis to discuss the radiological findings.
Thank you, Dr. Kaushiki. Good morning, respected dignitaries, faculty members, seniors and colleagues. I am Dr. Ayushi Sharma, first year radiology resident. Patient was further referred to Department of Radiodiagnosis. Imaging was done outside and the radiographic features are as follows. Before proceeding with the chest X-ray findings, I would like to ask the audience what could be the probable diagnosis. So this is a chest radiograph PA view suggestive of multiple nodules of variable sizes seen scattered in bilateral hilar and predominantly in lower lung zones. These nodules are mostly in favor of metastatic lesions. X-ray LS spine lateral view is suggestive of collapse compression of L1 vertebral body with vertebra plana. Further MRI LS spine was done. These are the T2 sagittal and T2 axial images of LS spine showing altered signal intensity involving L1 vertebral body with its complete compression collapse fracture. There is altered signal intensity with discontiguous involvement of D7, D12 and L1 vertebral body, with few of them showing involvement of posterior elements, especially the D7 pedicle. At L1 vertebral body, axial sections were taken, which shows altered signal intensity with bulging of posterior cortex of L1 vertebral body, causing severe narrowing of spinal canal, narrowing of left neural foramen,
so
and
pointers se demonstrate karo.
Yes.
What are you saying where?
So at L1 vertebral body, axial sections were taken, which shows altered signal intensity, showing bulging of the posterior cortex of L1 vertebral body, narrowing of the spinal canal, narrowing of the left neural foramen, and impingement of the left exiting nerve roots. These features in a known case of carcinoma suggest vertebral mets and lung mets. The involvement of posterior elements and sparing of intervertebral discs suggests possibility of metastasis over any other infectious causes. Now, I would like to invite Dr. Kaushiki to carry forward the presentation. Thank you.
Now I will be discussing the PET findings of this patient. This is the 3D image or maximum intensity projection image of PET-CT patient showing physiological uptake and few focal areas of FTG uptake in chest region, predominantly on the right side. Non-FTG avid soft tissue lesion was noted in the right thyroid bed region. There was a large lytic expansile lesion in the L1 vertebrae with associated significant soft tissue component extending into the spinal canal, causing luminal compromise with retrolisthesis of dorsal spine over the lumbar spine. In addition, multiple skeletal lesions were found in the body, with low-grade FTG avid lytic expansile lesions also involving the dorsal lumbar vertebrae. There was a low-grade FTG avid lytic expansile lesion with large soft tissue component at the posterolateral border of right 8th rib. There was a lymph nodal mass which was also low-grade FTG avid with mild right-sided pleural effusion. There were low-grade to non-FTG avid multiple bilateral lung nodules in both the lungs. So the final findings were low-grade residual recurrent disease at post-operative bed, mediastinal lymph nodes, widespread lung lesions, lytic bone lesions with significant soft tissue component, with the critical site being L1 vertebra. After the disease burden was assessed, we knew that the decision to manage the critical lesion at L1 vertebra was important. This case was discussed in a multidisciplinary tumor board, and we had two options to begin with: palliative radiotherapy to the critical lesion or surgical fixation of the vertebra. The collapsed vertebra and involvement of spine posed high risk of destability and was causing severe pain, rendering the patient wheelchair bound. So the final decision was to go for neurosurgery intervention. To discuss it, I would like to call Dr. Vartika to take this case forward.
Thank you, Dr. Kaushiki.
So my question to both of you is, how do you decide radiotherapy versus surgery?
Sir, that would be discussed further. Yes, sir.
Okay.
Good morning, respected teachers and colleagues. I am Dr. Vartika from the Department of Neurosurgery. So we received a reference from the Department of Nuclear Medicine for a female of 66-year-old female, and she presented with back pain with radiation to lower limb since last 9 months, weakness of bilateral lower limb since last 6 months, and numbness and decreased sensation below the inguinal region bilaterally since last 4 months. On CNS examination, the patient was conscious and oriented. The motor examination of the upper limb was normal. The motor examination of the lower limb suggested spastic paraparesis with increased tone in the bilateral lower limbs with exaggerated reflexes and bilateral extensor plantar reflexes. The sensory examination was suggestive of saddle hyperesthesia with decreased sensory impairment below the L1 dermatome with spastic gait. These findings were suggestive of L1 vertebral myths. On clinically correlating this finding with the imaging finding, we found that there was pathological collapse of L1 vertebra due to metastasis with focal angular kyphotic deformity at thoracolumbar region and additional metastatic deposit at D7, D10 and D12. The clinical radiological findings were suggestive of mechanical instability at D12 L1 level. Therefore, we decided to proceed with the surgery of fixing the level L1 2 levels above and 2 levels below the diseased segment. Therefore, we proceeded with D11, D12, L2, L3 pedicle screw fixation with D12 L1 laminectomy and spinal cord decompression. The patient tolerated the procedure well without any post-op complications and was discharged on POD4. Thank you. Now I invite Dr. Sahil to take the case forward. So coming back to your question, since there was neurological deficits which were present due to L1 compression and they were progressive in nature, we decided to fix that segment first and then later continue with the palliative therapy.
So you could have had almost the same response with radiotherapy also.
So the
Why
patient
choose
was in
surgery?
severe pain and we wanted him to get rid of it.
So there is excellent pain relief with palliative radiotherapy also.
So also there was progressive neurological deficits like weakness and numbness in the bilateral lower limb.
So when you give radiotherapy and you decrease the soft tissue mass, there is improvement in neurological symptoms also.
So it takes time like we wanted.
So the important thing is that you have to keep the disease scenario into question, right?
Yes,
If
sir.
there is a short survival, then you don't want surgery done. So
Yes.
that is one of the key factors. If you have a tumor which is chemo-radio resistant, then you end with a long survival, several months, several years of survival, then you incline towards surgery. Otherwise, if there is a short survival,
Yes, sir.
poorly responsive tumor, then you go not do the surgery, go for palliative radiation.
Yes, sir.
The general question is,
Yes, sir.
after how long of the paralysis onset will it recover? So should you do the surgery or you should just give radiotherapy?
So,
we can grade the power according to grade 5 to 0. Okay. So if we are having even grade 1 or 2 power which has left, we should always try for the surgery. And another question was Dr. Hemant Malhotra sir was asking, in addition to that, what she told, the most important thing is that there was junctional kyphosis, which was at the level of cord. Though the adjuvant therapy might heal the lesions, but in the deformed way. So if there is kyphosis and that will progress, there will be 100% stretching over the cord or the spinal cord. So if we take this into consideration, if we are working above the level of L1 where the cord ends, spinal cord ends, so we always go for surgery and the early intervention. Thank you.
But when would we not do surgery? Means the patient is already has paralyzed. When would we not do? Tell them कि नहीं अब कुछ नहीं हो सकता है.
Sir, we should give an offer to every patient, but this should be very well explained to the patient. That is my point.
But I think the case was decided for surgery in tumor board, so medical oncology, surgical oncology, all should have been there. And it should have been a very conscious decision to go for surgery.
Absolutely, sir. In a patient of low-grade thyroid carcinoma with the therapies available which will come to subsequently, survival for many years is possible. So we had no hesitation in recommending surgical decompression.
thank you, sir. Now I invite Dr. Sahil to take the case forward.
Thank you, Dr. Vartika. Good morning, respected dignitaries, faculty members, and my dear colleagues. I am Dr. Sahil Kalavdia, second year PG resident from Department of Nuclear Medicine. So after the spine fixations, surgical specimen was sent for the histopathological examination, which revealed metastatic follicular carcinoma of thyroid, and also the sample was also sent for the next generation sequencing, which turned out to be negative for all the markers. Now we have a known case of metastatic follicular carcinoma of thyroid, post-thyroidectomy, post 2 doses of radioiodine therapy, post radiotherapy and spine fixation. The patient came to us for the follow-up after 6 weeks, and then the definitive radioiodine therapy, which is the primary treatment for the residual as well as the recurrent metastatic disease post-thyroidectomy, was planned. So before giving any radioiodine therapy, we classify the patient according to the ATA risk stratification. Now in our patient, the patient had distant metastasis, so the patient belonged to the high risk group, and therefore high dose radioiodine therapy 200 to 250 depending upon the tumor burden it's planned. In this patient we had planned for 250 because patient had high tumor burden. So there are certain prerequisites before giving an RAI therapy, and one of the most important is the serum TSH level should be more than or equal to 30 milli international unit per liter. In our case, the patient had suppressed TSH levels, so there was no option of hormone withdrawal method. So we only had the option of the recombinant TSH administration prior to the RAI therapy. Other than that, the patients are advised to avoid the stable iodine before RAI therapy. It can either be in form of iodine-based antiseptics or cough syrups containing the iodine. Also, the patient should avoid iodine-rich foods, and also there should be no history of any iodinated CT contrast before RAI therapy. Plus, diagnostic iodine 131 whole body scan is preferable. So there were certain challenges in this patient. Firstly, the low TSH level due to high functional meds. For that, we had already planned recommended TSH administration. Secondly, there was risk of exacerbation of symptoms due to the RAI-induced transient inflammation in pneumonitis, for which steroid cover was planned. And there were relatively low SpO2 level, for which O2 support and monitoring was planned. Other than that, the patient had poorly controlled blood glucose levels. For that, we had already referred the patient to the Department of Endocrinology. And for pain management during as well as after the therapy, we had referred the patient to the Department of Palliative Medicine. Also, keeping in mind the risk of the tumor flare-up post radioiodine therapy, Department of Critical Care was also requested to reserve an isolated ICU room on standby if any such need arises. Now I would like to call Dr. Lavanya from Department of Palliative Medicine to discuss the pain management done during as well as the after discharge of the patient. Thank you.
Thank you, Dr. Sahil. Good morning, respected. Thank you, Dr. Sahil. Good morning, respected dignitaries, faculties, and my dear colleagues. I am Dr. Lavanya from the Department of Pain and Palliative Medicine. So this was a 66-year-old female who was an operated case of metastatic follicular carcinoma of thyroid. At the time of referral, the patient complains of pain in lower back, which aggravated since 1 month. The pain was gradual in onset, continuous, severe in intensity, associated with tingling sensation, and was aggravated by movements. She was already on buprenorphine patch 5 microgram per hour, tablet gabapentin 100 milligram 12 hourly, tablet tapentadol 50 milligram 12 hourly. With this ongoing pain management, she reported a pain score of 7 on 10. Initial palliative care assessment was done in this patient, including the Edempton symptom assessment score, which showed a score of 36, highlighting the overall symptom burden to be higher in this patient. Further assessment of the patient was done using the palliative performance scale, which takes into account the patient functional status. Her palliative performance scale was 70%. The palliative prognostic index is used to predict the prognosis of the patient, and it takes into account the palliative performance scale, oral intake, edema, dyspnea at rest, and delirium. For this patient, the palliative prognostic index was at 1 because she had only reduced oral intake. Patient was managed based on the total pain model, addressing the physical, psychological, social, and spiritual domains. Based on the World Health Organization analgesic ladder, treatment was initiated. The patient was started on fentanyl patch 25 microgram per hour to be changed after 72 hours. Non-opioid analgesic like injection diclofenac 75 milligram IV 12 hourly was advised. Injection paracetamol 1 gram IV was advised as required. Adjuvant analgesics like gabapentin, amitriptyline 150 milligram by 5 milligram was also advised 12 hourly to taper the neuropathic component in this patient. After 4 days of treatment, the patient pain score improved from 7 on 10 to 1 on 10. The patient was discharged on fentanyl patch 25 microgram per hour, tablet paracetamol 650 milligram 12 hourly, tablet gabapentin, amitriptyline 150 milligram 5 milligram 12 hourly, along with multivitamin and proton pump inhibitors. She was on regular follow-up with the department, and her pain remained well controlled, allowing gradual de-escalation of the analgesics. The patient is currently on etoricoxib 45 milligram SOS. Thank you. Now I would like to invite Dr. Sahil to continue further. So both belongs to the category of strong opioids, but in this patient we selected fentanyl patch because she already had shortness of breath. So fentanyl patch has reduced effect on the respiratory depression. So we chose this. No sir, fentanyl patch we have to change in every 72 hours. Buprenorphine has to be changed in 7 days. It acts longer, sir. Thanks.
Thank you, Dr. Lavanya. Now take the case further. As we had already discussed, recombinant TSH administration was planned prior to the RAI therapy. The patient and the guardian were explained about the procedure as well as the side effects following the RAI administration, and thus the written and informed consent was already taken. Now coming on to the RAI administration, Recombinant TSH costs approximately around 90,000 rupees, and it contains 2 vials, each vial containing 0.9 mg of the recombinant TSH, and both the vials are given 24 hours apart on the 2 consecutive days, and following the second vial administration 24 hours after that, we administer the radioiodine therapy. So we can see the effect of the recombinant TSH administration. Before recombinant TSH administration, the TSH values were less than 1, and after recombinant TSH administration, it raised about more than 400. Now coming on to the administration of the radioiodine therapy, patient was asked to fast for 4 hours prior to the therapy, and certain pre-medications were given. Ondansetron as well as the dexamethasone was given prior to the RAI, and high dose 250 millicurie radioiodine therapy dose was administered orally to the patient. Now let me give an overview of how does the uptake as well as the action of the radioiodine occurs inside the body. So after oral administration, radioiodine is absorbed in the bloodstream through GI tracts, mainly the stomach and the duodenum. From the blood circulation, it is taken up by the sodium iodide symporter present on the surface of the thyroid follicular cells, and after being inside the thyroid follicular cell, it emits 2 types of the radiation, beta radiation as well as the gamma radiation. The beta radiation causes the DNA damage and helps.
Sahil, explain symporter.
Along with this, along with the sodium, 2 ions of the sodium, it also transports the iodine on the same direction.
So does it require ATP? Or it is the 2 molecules which take the iodine or anything inside?
It is active transport, sir. Active transport, therefore it requires ATP.
No, it doesn't require. This is the difference. Okay. Symporter, because 2 molecules are going. What is antiporter?
Opposite direction. And
which cell, which organ in the body is doing that? Which organ which is every day seen?
Antiport, sir.
Antiporter. Influx of calcium in the cardiac muscles.
Yes.
Alright? And here it is influx of the iodine in the, because 2 sodium molecules, they are draining it or pulling it to the.
Okay. Along with that.
Okay. So you should know the mechanism, fundamental.
Okay. Sorry. So the beta rays.
Just for the audience sake, what is the difference in low dose uptake, what is the intermediate uptake, and what is the high dose therapy?
Uptake of the radioiodine?
Yes. Any uptake for that matter. Okay. There may be a receptor uptake also. No?
In the case of the thyroid cancer, if it is a highly iodine heavy, there would.
What is low dose therapy?
Low dose uptake, it would like the amount of dose administered, it will have less amount of the.
What is the dose? You are in nuclear medicine, yes, and you should know what is the dose for the.
Okay, so low dose is given in the Graves. There is 30 millicurie approximately.
Low dose can be used for diagnostic purpose, isn't it?
2 millicurie dose is given in the diagnostic purpose, 30 millicurie given in the benign conditions like Graves' disease, hyperthyroidism, and also the 50 millicurie is given in the low risk patients, 100 millicurie is given in case of the intermediate risk patients. In high risk patients, depending upon the tumor burden, 200 to 250 also given. If the patient has lung metastasis in the intermediate, then 150 millicurie of radioiodine is given. If the patient has the bone mass, then we can give 200 also in that patient. So coming on to the 2 types of the rays, the beta rays causes the cell damage and helps in the destruction of the cancerous cells, whereas the gamma rays which travels longer and they are helpful in the imaging purpose. So this on the left side, this is a picture of a high dose therapy radiopharmacy lab, and our RSO is dispensing radioiodine in the fume hood, which is an assembly working on the negative pressure. And why is it required? Because RAI is highly volatile, so we need a negative pressure for radiation safety purpose. In the middle upside, we can see the lead glass through which is helpful in like possible to work in the inside the fume hood. And on the lower side is the display unit, on the right side is the dose calibrator, which helps in dispensing the specific amount of the radioactivity to be administered to the patient. Now the RSO on the left side, the RSO is dispensing. In the middle picture, RSO is giving orally the radioiodine therapy to the patient. And on the right side, it is the high dose therapy isolation room, which is well equipped to handle most of the emergency scenarios if any such need arises. Sir, it depends upon the amount of the radioactivity given. So mainly there are discharge criteria. When the radioactivity levels are below the 5 millirongton per hour at 1 centimeter from the body surface level, we discharge the patient.
Monitor that.
Yeah,
such level has come, then patient can go home.
Yes, sir. After admission, we monitor. In cases of low dose, like we discussed 30 milligram grace, here we have given 250 milligrams. So generally, on practical basis, it takes around 5 to 6 days to come at the level of that. If it's low dose, it is OPD based only. We generally keep patient in surveillance for 2 to 3 hours. After then, we can discharge the patient also. If we have given 50.
Question is, generally is all right. What is the objective method you have for that particular patient to ensure that before going home, active iodine has come down to the accepted level?
Yes, sir. We measure the
objective.
Daily monitoring is done. We have the survey meters, and there are specific readings that the whole body burden should be less than 30 millicurie. That 30 millicurie represent 5 mR per hour. So at 1 meter distance at the umbilical region, daily monitoring is done. When the disease burden is high, the retention of the radioiodine is more, so the discharge will be later. It will take more days. Whereas only residual thyroid tissue, no meds, patient may be discharged next day only, because the burden will come down. So as per the regulatory bodies, Atomic Energy Regulatory Board in India, International Commission Radiology Protection all over the world, the dose should be, the whole body burden should be less than 30 millicurie, and even 30 millicurie, up to 30 millicurie, we can administer the dose as OPD patient.
So let me give you a chronological description of the symptoms, vitals, and the metabolic changes that occur in the patient. Day 0 and the day 1 were uneventful. On day 2, patient complained of mild shortness of breath, for which O2 support was started at 2 liters per minute for 2 hours. And on day 3rd, the patient complained of increased shortness of breath, and the oxygen saturation was 89%. Therefore, O2 support was given at 5 liters per minute for 8 hours, which was gradually tapered to 2 liters per minute after the oxygen saturation levels were reached to 93%. On the day 4 also, oxygen support was given, but for just 4 hours. On day 5, the patient was not having any symptoms. So, and also the radiation levels were less than the 5 mR per hour, which are the discharge limits. Therefore, we plan for the discharge, and before discharge, we generally do a post-therapy scan. Now, this is a normal iodine 131 whole body scan in a post-thyroidectomy patient, which is showing normal physiological uptake in the GI tract as well as the bladder. And this is a post-therapy iodine whole body scan of the patient, which is showing iodine avid uptake in the large foci in the mediastinal nodal mass and the right rib lesion, which was seen in the FDG PET scan. Also, there are few focal uptakes seen, which are corresponding to the bony mats, and we can clearly see there is a diffuse uptake in the bilateral lung fields, suggesting of the lung metastasis in the patient. Now, there are certain discharge prerequisites for the radioiodine therapy. As we had already discussed, the discharge limit should be less than 5 mR per hour at 1 meter distance from the body surface level, which are regularly monitored daily in the patient. Also, the patient should be clinically stable. Now, certain advice given at the discharge. Advice is given to the patient in the written instruction, bilingual written instruction form regarding radio-safety precautions to be followed at home during the isolation period. And the dexamethasone was continued for 1 month, followed by gradual tapering of the dose. And for the pain management and blood sugar control, regular follow-up was done with the Department of Endocrinology and Palliative Medicine. Now, patient was not advised for any thyroid hormone replacement, as patient had already suppressed TSH levels and due to high functional meds. So, there was no need of any thyroid hormone replacement.
Any isolation at home?
Yes,
the patient can mix
preferably
with the
patient should be at a distance, 3 meter distance from other person, and especially should avoid coming in contact with the children and the pregnant women. So depending upon the dose given, like generally we ask in case of 50 millicurie given, we ask the patient to take precautions for 1 week. If 100 millicurie is given, we ask for 15 days. More than that, we generally maximum 3 weeks we ask the patient in case of high dose therapy.
How will he or anybody will maintain metabolism without thyroid replacement therapy?
Sir, the body is already having functional meds. Functional meds means the metastatic disease, they are self-sufficient self-sufficient for the body requirements. They are producing thyroid hormones which are self-sufficient for the body requirements.
Our duty to destroy those other metastases, otherwise it further spread. Okay.
No, sir. Also, the patient was kept on regular telephonic follow-up for 4 weeks at an interval of 2 to 3 days. Now, this is a summary of the 1 month, 3 months and the 6 month follow-up. Other than nausea, no other side effects were reported by the patient in the post-therapy period. At 6 months, ECOG performance status changed from 3 to 2. Serum thyroglobulin level came to be 46,329, almost half of the pre-therapy levels. And the patient has now clinically and biochemically improved. So we had planned for an FDG PET for disease response evaluation. So this is the MIP image comparing the pre-therapy as well as the post-therapy FDG PET scan. We can see there is significant reduction in number of the FDG avid lesions also. Here we can clearly see there is significant reduction in the soft tissue component of the 8th rib lesion compared to the this is the pre-therapy, this is the post-therapy. Also the number of the lung nodules as well as the size of the lung nodules have been drastically reduced. Now the mediastinal mass also showed significant reduction in size, and the L1 vertebrae showed significant reduction in the soft tissue component. So to summarize it, there was a significant response to the treatment, but the residual disease was still there. And to treat that residual disease, the 4th dose of the radioiodine therapy was planned. This time also the patient had high functional meds and the suppressed TSH. Again we gave the recombinant TSH and post recombinant TSH 250 millicurie dose, that is was the 4th RAI dose was administered under strict radio safety precautions and steroid cover. And this time no adverse effect or event were noticed during the hospital stay. Now this is the comparison post-therapy whole body iodine scan. Here also we can, corresponding to the response we saw on the FDG, we can see significant reduction in the iodine avid foci. This was the mediastinal mass showing significant reduction in the size. This was the right lytic lesion showing significant reduction in the size, and also the bony mets also showed significant reduction in the avidity. After the radiation levels fell under the discharge limits and the patients were vital, the patient was discharged with advice of tapering of steroid once again and precautions to be followed at home. This is a graphical representation of the tumor biomarker, that is the serum thyroglobulin, over the time showing decreasing trend. Especially we can clearly see this was the peak before the patient came to us, and before the 3rd radioiodine dose it was around 1 lakh, more than 1 lakh. This was then after 3rd and 4th cycle it has been continuously decreasing, and the latest serum thyroglobulin levels are 10,662 nanogram per ml. In view of and post therapy follow-up, after 1 month the TSH came out to be 7.49 milli international unit per liter. Therefore, signifying that the functional meds have now decreased, and now there is a need of thyroid hormone replacement. So for the management of thyroid hormones, we referred the patient to the Department of Endocrinology. Thank you. Now I would like to call Dr. Sumegha to take the case forward.
Thank you, Dr. Sahil. Good morning, respected dignitaries, esteemed faculty and dear colleagues. I am Dr. Sumegha from Department of Endocrinology. So far the patient is a known case of metastatic follicular carcinoma, post-total thyroidectomy, post-radiotherapy and post-4 doses of radioactive iodine therapy. Now this graph here, it shows the trend of serum TSH levels during the patient's treatment course. For most of the follow-up period, TSH remained suppressed despite the patient not receiving thyroxine. This was likely due to functioning metastatic follicular carcinoma producing thyroid hormone resulting in TSH resulting in endogenous TSH suppression. The prominent peaks here seen in the graph, they correspond to TSH measurements which are obtained following thyrogen administration before radioiodine therapy. Notably, approximately 1 month after the fourth radioiodine therapy, the serum TSH was around 7.5. Now, according to the dynamic risk stratification approach, our patient demonstrates both a biochemically incomplete response as well as a structurally incomplete response. So here we targeted that the TSH should be below the normal reference range of normal, below the normal reference range, and clinically we target for TSH less than 0.5 in such cases. So the patient was started on tablet levothyroxine 75 micrograms per day empirically. So I would like to call Dr. Tarun Kumar Jain, Sir, Associate Professor from Department of Nuclear Medicine, to take the presentation forward.
Thank you, Dr. Sumedha, and good morning, everyone. And myself, Dr. Tarun Kumar Jain. I am Associate Professor in Department of Nuclear Medicine, and I am concluding the case. Patient is coming in follow-up without any symptoms, relief from pain and dyspnea, and patient is ambulatory and can perform the daily routine activity without any support. For the monitoring of the hematological toxicity, we are regularly performing the CBC to allow any bone marrow suppression. Now we have already given the 800 millicurie, so we have a reserve of the 200 millicurie with us. If we needed in future, we can use it. So there are few reasons for selecting this case. This case is demonstrating the RAI as a definitive treatment. Most of time we are using RAI as a adjuvant setting. After the total thyroidectomy, we are giving RAI for treating the residual disease. But in this case, we are treating as a high burden metastatic thyroid cancer, and we found the remarkable improvement in the quality of the life in the patient from wheelchair bound to the fully ambulatory. And this case is showcasing of the therapeutic power of the nuclear medicine. It is breaking a myth that we are doing only the diagnostic scans. We are also having a potent, highly targeted therapy with us. So we are not only the diagnostic department, we are also therapeutic department. And in our experience, we have started the RAI therapy in 2019 with the low dose, in form of the low dose therapy with up to the 30 millicurie. And in addition of the high dose therapy unit in 2022, we started the full-fledged radionuclide therapy with us. In our team, we have a RSO, nuclear medicine physician, well-trained nursing staff, and male and female helpers. During the treatment, we are following the ATA guidelines. ATA is American Thyroid Association, and we are treating the all age group patients with us. And this is the graphical presentation of the treated cases with the duration of the years, and we have treated more than 370 cases, and there is no experience of the life-threatening event till now. And not only we are doing the radioiodine therapy with us, we are also doing the lutetium-based PSMA therapy for the treatment of the prostate cancers and lutetium dotatate therapy for the treatment of the neuroendocrine tumors. Along with this, we are doing the yttrium-based using the yttrium-based thyrospheres with us, and with the help of the Dr. Nikhil, and we have already done the 7 cases for the SCC, and also along with us, we are also using the strontium and samarium therapy for the bone pain palliation. But due to lack of the standard laboratory or diagnostic facility, we have till now not started the alpha therapy. So we are requesting to management, please provide the high-tech radiopharmacy lab so we can start the alpha therapy along with us. So after the Bhagwan Mahavir, and we are the second unit who are doing the radionuclide therapy with us in the Rajasthan. So the take-home message from this case is that this is not a single department approach, or without the support of other department we cannot perform or treat in such type of the cases. We have received a very good support from the corroborating departments like Neuro-surgery, who timely stabilize the spine, and the precise diagnosis are received from the radiodiagnosis department. and the palliative medicine have dramatically managed the pain, and endocrinology department is caring the diabetes and the thyroid hormone. So finally I am showing the some views of the patient in her language. And
मुझे लेटने बैठने उठने में दिक्कत होती थी। इसका इलाज मैंने महात्मा गांधी हॉस्पिटल में कराया। वहाँ मुझे 2 आयोडीन थेरेपी दी गई, जिससे मुझे दर्द में आराम है और मुझे सांस लेने में भी कोई दिक्कत नहीं है। मैं अपना काम सारा नॉर्मल तरीके से कर लेती हूँ।
So this is the patient views in her language, and so finally I am concluding and I am closing this case, and I want to give the thanks to the patient and her family who trusted on us and taken a treatment with us. And I want to give the thanks of the management of MGUMST who is providing the constant support and giving the well performed infrastructure so we can do these type of the cases at us. And also give the thanks to the other coordinating departments, Neuro-surgery, Radiodiagnosis, Endocrinology and Palliative Medicine. And I also want to give the thanks to our RSO who are constantly getting exposure of radioactivity during the monitoring of the patient, nursing staff and technical staffs. And I also want to give the thanks of CCR Review Committee, Dr. Jaiswal sir, who constantly in learning us timely. And I want to at last I want to give the thanks to audience who sincerely listen us. And